Okay, welcome back everybody. Our next presenter is Dr. Chantelle Erwee, and she's been the technical manager for dairy small stock reproduction and genomics at Zoetis for the past 5 years. She's been in the industry for about 10 years. She's currently busy with the MSc in veterinary epidemiology, and she's based in George. And she will continue now with her presentation on udder health and mastitis. Dr. Chantelle, welcome, and thank you for sharing your expertise with us today.
Thanks, Elena. Really appreciate the opportunity. It's really nice to always be a part of the dairy school. We always enjoy, any interaction with the students. So today I will just be, can we maybe just mute? There's some background noise that I'm hearing. Sorry. So basically what I am going to discuss with you today is just an overview of udder health and mastitis, because I think it's so important that we know the basics of mastitis and then work from there, because I think also a lot of our treatment options and a lot of what we decide to do in terms of the management of that mastitis will then go from there. Okay, so it is quite a hefty presentation. It's quite a few slides. I'm going to try and work through it as quickly as possible without rushing through it. But let's just look at mastitis and what do we mean when we say mastitis, right? And this might sound a bit obvious, but mastitis is actually often used for bacterial but it is actually a non-specific term, and it refers to the inflammation of the mammary gland. And that is actually from any cause, whether it be infection or injury, etc. But for today's purposes, we will be, when we say mastitis, we will be talking about a bacterial origin mastitis, right? So usually when it is a bacterial mastitis, and we'll talk about the different ways in which the udder tries to protect itself. But usually when we talk about mastitis, that means that that bacteria has managed to get through all the barriers, and it has actually breached that teat canal, and it has reached the inner area of the udder, and it can do that within minutes, and it can actually penetrate those milk-producing epithelial cells very quickly. And then from there, that bacteria, depending on which bacteria it is, then can actually release toxins, causing even more local inflammation and sometimes even a systemic illness. All right, so there is self-cure possible, especially with our environmental mastitis cases. However, if this is left too long, the effect or the consequence thereof is necrosis, right? So there's destruction of those milk secreting epithelial cells in the alveoli, and that can obviously then have other consequences such as fibrosis and obliteration of those milk secreting cells, meaning that they don't have capacity to produce milk anymore. All right. So this is what I've just said. Those alveoli are replaced by connective tissue, scar tissue, and that just permanently reduces that that cell's ability, to actually produce milk. Okay, then because of that necrosis and the debris that is formed as a result of those bacterial toxins, that can actually cause a blockage of those alveolar ducts. And that, in effect, then has an effect on, excuse me, on the effectivity of the intramammary antibiotics that you try and put into that udder to try and treat it. If it's blocked, it can't reach those areas, or if there's fibrosis in terms of connective tissue, scar tissue, it can't actually reach those areas and be where it needs to be effective. Okay, udder immunity. So we're not going to go into a whole immunology lecture today, but just the basics of the immune system and how it relates to the udder. So you'll remember that the immune system has a non-specific and a specific arm. And on the non-specific side, we have mechanical barriers, and then we have the innate immune system. And then on the specific side, we have the humoral and the cell-mediated immunity. Okay, so let's look at the components of the immune system and how that relates to udder immunity. Okay, the udder is usually quite a sterile environment. So when bacteria gets in there, it results in inflammation and infection. So when we look at the mechanical barriers, so those would be our first line of defense, and these would be physical barriers. We would be looking at the teat skin, the keratin plug, as well as the teat sphincter. Okay. So looking at the first one, the teat skin. Although it is not a sterile environment at all, it's also not really supportive to bacterial growth. It has keratin, which does not support bacterial growth, and then it also secretes some bacteriostatic elements, which then obviously can hamper the bacterial growth as well. However, if there's any damage to that teat skin, or there are cuts or cracks or whatever it might be, this could actually create an opportunity for that bacteria to get in and cause infection as well. Right, so when we look at the dry period, so towards the end of lactation, that teat canal closes, and in most cases, and I'll say I'll put emphasis on that, and you'll see why later. But that teat canal is sealed within about 8 to 10 days with what we call a keratin plug. And that plug is actually secreted by the cells that line the teat canal. And this keratin plug is very, very important because it forms a physical barrier from ascending bacterial infections. It also has antibacterial properties inherent to it. Okay, and then let's look at that muscle that causes the teat canal to actually close, that teat sphincter muscle. And it's important that that muscle is not damaged, and that it can actually maintain a tight closure, once again, to prevent those ascending bacterial infections. So any trauma or injury to that muscle can actually then result in leakage because of the fact that it might not be able to close tightly, and then obviously leave that udder and that teat canal and that udder more susceptible to ascending infections. And this is especially important when we are busy administering any intramammary, that we do it carefully. So two things with intramammary administration: the one is careful, and the other one is hygiene, right? So because of the fact that we can actually damage that muscle that's supposed to be closing that teat canal, and if we do that, it can't close anymore, and like I said, create that environment for ascending bacteria. The other one is hygiene, because of the fact that you can actually introduce bugs that weren't in the udder with an intramammary administration. Okay. Okay, so let's look at some other non-specific bacterial inhibitors that are in the milk. So lactoferrin might be one that you've heard of before, and this actually is a protein that binds to iron, and a lot of bacteria need iron to grow, and because of the fact that the lactoferrin has now bound that iron, it's no longer available for the bacteria to grow. Okay, the levels of this lactoferrin is the highest in the mid-dry period, and that is also when the animal is the least susceptible to infections, is that mid-dry period. Okay, then there are other elements, the lactoperoxidase, that also it's an enzyme that has antibacterial properties. immunoglobulins or antibodies, and then macrophages and other leukocytes. Okay. So once, let's say the pathogen has now actually managed to gain entry into the mammary gland, it's gone through, it's bypassed the teeth skin's protective mechanisms, it's bypassed the teeth sphincter muscle, it's there, let's say there wasn't a keratin plug formed and now it's managed to actually traverse that teeth canal and now it is, it's gained entry. Then there are other facets which we all then will in general call the innate immune system that will then be crucial, right? But in order for them to actually do their job, firstly, the pathogen needs to be recognized. Okay, so it needs to be seen and recognized, and alarm needs to be made, basically, right? And then once it's been recognized, an immediate and effective response needs to be launched so that that pathogen can be eliminated and controlled as quickly as possible. All right. So that pathogen recognition that I just spoke about, that is especially important because of otherwise this pathogen can gain entry unseen and go and wreak havoc in the udder. Okay, and it's the mammary gland is actually quite special in this way, in that the mammary epithelial cells are quite critical, that and they can actually recognize some of these pathogens. Okay, I'm not going to go into specifics with toll-like receptors and all those things, but it is quite interesting. So if you would like to go and read up on that, on how these epithelial cells actually do this. Then once they've recognized or identified this pathogen, the epithelial cells themselves secrete certain immune-related factors that can help fight the pathogen, but also it causes an upregulation of the immune response and causes various factors and inflammatory mediators, leukocytes, etc., to then be produced and come and help in the fight, right? So the fact that this needs to happen quickly cannot be underestimated or overestimated, um, especially when we look at infections, for example, E. coli, where um, even if there's a delay of an hour, this can lead to an 8-fold increase in E. coli numbers, right? So that delay can be anything from, just genetic inherent in the genetic makeup of the animal, that they're just slower responders in terms of the immune system. But it can also be that the animal might be immunosuppressed, as we often see around the time of calving. All right, so many factors that can influence this rapid recruitment of the immune cells into the mammary gland. Okay, somatic cell count. So we often hear the term somatic cell count, and I always wonder if everyone always knows what we refer to if we say somatic cell count. Um, so I'm going to take it from the basics in terms of what somatic cell counts is, why do we look at somatic cell counts, and what do they mean? All right, so it's an indirect measure of what is going on in that mammary gland. What is the inflammation in that mammary gland? So there's a general threshold that we consider of about 200,000. This can differ, right? So it maybe different milk buyers will have different thresholds, and also on farm they might have and certain vets might have stricter thresholds, and it all depends on I think also if we are looking at, say, um, different remedies that we are going to use to treat mastitis or to maybe try and prevent mastitis. Usually we look at about 200,000, but there's a saying that I like: the greater the fear, the lower the threshold. So let's say internal teeth sealants that we're going to talk about a bit later. if you have a fear of just putting in an internal teat sealant without an antibiotic, for example, this threshold will come down to, say, your threshold will be we'll be looking at about 50,000 or 100,000 or whatever. Okay, so what is the somatic cell count? It's mostly made up of immune cells, so lymphocytes, macrophages, neutrophils, and then partly epithelial cells of the udder. Okay, so healthy glands will have predominantly mononuclear leukocytes that are basically just floating through, so macrophages, lymphocytes, and as soon as there's inflammation, there's quite a dramatic shift from those mononuclear leukocytes to more polymorphonuclear leukocytes like neutrophils. Excuse me. Okay, so when what happens during an infection is that leukocytes are actually recruited from the circulation, and how quickly they are able to move from the circulation into the tissue and then into the milk. That is actually very, very important, because that is what determines how effective the immune response to the pathogen is going to be. So obviously, because of that recruitment process, this will increase the somatic cell count in the milk. But it is important to know that a low somatic cell count does not necessarily automatically mean that there's no infection. So often what happens with clinical mastitis caused by coliform infections is they have an initial rise in somatic cell count and quite a high rise in somatic cell count, and then it goes back to almost, I want to say, normal. But just maybe around threshold or about to what it was, maybe a little bit higher. And you might then miss, let's say you take the somatic cell count of that animal after that peak, you might not find anything amiss because of the somatic cell count not being something that it's not as high so that it would draw attention. And in fact, what they've seen is that coliform infections, herds with lower bulk tank somatic cell counts are actually have actually been associated with more coliform infection. Right, so this shift of somatic cell counts into the milk can be quite dramatic, like I said, and it can increase to up to millions of cells per mil in severe cases of intramammary infections. All right, so when I talk about bulk tank somatic cell count, just so that if you're unsure, I'm referring to the somatic cell count that was taken from the milk from the bulk tank rather than the individual samples, individual animals. Okay, so then once these neutrophils have managed to then enter the udder tissue and the milk, they can engulf and kill the bacteria, the pathogen that entered into the udder. And they are usually quite effective, but the response is not foolproof. And like I said, it can be hampered by anything that will suppress that immune system. So let's say it's an overwhelming infection, that increase in somatic cells or increase in neutrophils can maybe just contain the infection, but might not be able to eliminate it. And then, like I said earlier, different animals will have different degrees and speeds in terms of how quickly they can and how effectively they can actually recruit these cells into the udder. So unfortunately, like with anything, if inflammation carries on for too long, it can then lead to that udder damage. Important when we vaccinate against mastitis to know that it's not a substitute for poor management, right? So It's just one component of an overall plan that we use to try and help control mastitis. So we need to look at a systematic approach. We need to look at all the management practices, proper milking procedures, nutrition, and then in addition to your vaccination programs. So unfortunately, most vaccines that are against mastitis pathogens will not necessarily give a long-lasting immunity or even a full, it won't necessarily prevent the infection from occurring, but it will help shorten the duration and indirectly, therefore, shorten the or limit the damage that is done to that outer tissue, and then also reduce shedding. So, and by doing that, reduce the infection pressure in the environment. Okay, so this is just one example. This is one of the Zoetis vaccines that I've just put up, and like you'll see there, that it's a three-dose regime, and this three-dose regime needs to be repeated annually. So this year I give a three doses according to what you see there on the screen. Next year I need to repeat all 3 doses, or at the next dry off I need to repeat all 3 doses. And this is just because we need to vaccinate during high risk periods. Okay, and if you vaccinate now, it will not necessarily carry through to the next high risk period or the next dry off. Okay, unfortunately with these types of vaccinations, the immunity is not long lasting. What they did find, however, was that there was quite a significant reduction in the duration of E. coli mastitis. Okay, so this specific vaccine that I'm talking about now is one of our vaccines against E. coli mastitis, and what they found was that there was 60 in the vaccinated animals, the duration of the E. coli mastitis was 64 hours shorter, right, compared to the control animals, and then also there was significantly less of the E. coli bacteria shed into the environment during the 3 weeks post-challenge compared to the control. Okay, so let's look at the different mastitis pathogens. So there are many mastitis pathogens. If you look at a lab report, I recently looked at a lab report of one of the farmers, and there were so many pathogens on there you can't even imagine. But we just are going to focus on the main ones, and those are the ones that you see on the screen here. Okay. We'll look into gram-positive versus gram-negative. So just so that you understand, gram stain is just a special stain. It differentiates between the different bacteria based on the peptidoglycan properties of their cell walls. Some with a large layer of peptidoglycan will keep the dye when it is washed with ethanol, and those are gram-positive bacteria, whereas gram-negative bacteria has a thinner layer of that peptidoglycan, and when it's washed with alcohol, it loses the dye and then appears red or pinkish. Okay. Right, so just to differentiate between the different mastitis pathogens, as you'll see there on the screen, your Staph aureus, your other CNS, your Strep uberus, Dysgalactia, Agalactiae, etc. Gram-positive, your gram-negative, we're looking at is E. coli, Klebsiella, etc., and then some others, Mycoplasma, etc. All right, so then when we classify them as contagious versus environmental, your Staph aureus, contagious. Your CNS, there is some debate. Some people do say that they can also, some of them have also been found in the environment. Strep Agalactiae, Corynebacterium, and then your Mycoplasma bovis, and your environmental bacteria, your E. coli, your Klebsiella, etc. And then your draadsitters, or your fence, sitting on the fence bacteria is your Streptococcus aureus and your Streptococcus dysgalactiae, meaning they can be either contagious or environmental. Right, so when we look at contagious mastitis, we often characterize it as, this is spread from quarter to quarter or cow to cow in infected milk, and it's usually at milking time. So the source of infection is that udder of infected cows, and it's transmitted by the milking machine or the operators through their hands, washcloths, sponges, or anything that they use without proper hygienic measures between animals. So it can lead to a chronic subclinical infection that sometimes has periodic clinical episodes, right? So you'll see the history of the animal that she has periodic clinical mastitis. She most likely has subclinical mastitis in the periods in between. Right, so the often culprits are Streptococcus agalactiae and Staph aureus. And very important that we control this by improving hygiene and handling practices. Our environmental mastitis, this usually results in a clinical mastitis, and the source is the environment, right? This is very hard to control because you can't really get rid of the environment. High risk is usually in the early and late dry period, as well as early lactation. And then often what we see is that a dry cow often can get an intramammary infection and of environmental origin, and then it stays quiescent, it stays quiet until the next lactation, and then actually it's a clinical mastitis, but it was originally obtained in the dry period, and we'll look at that a bit later as well. Okay. Okay, this is usually caused by our gram-negative bacteria such as our E. coli, or then that Strep aureus and Strep galactia that I just mentioned as well. Like I mentioned before, that CNS, coagulase negative staphylococcus, has also been implicated in environmental mastitis. Okay, so just a summary. I'm not going to go through all of this. You will be receiving this presentation. But just as a short summary, the contagious mastitis, and this is general, all right? So it's not necessarily going to be the same with every pathogen and every case, but in general, your contagious mastitis causes an increase in your somatic cell count, as well as usually a subclinical mastitis and sometimes with spikes of clinical mastitis or intermittent periods of clinical mastitis. And then your environmental mastitis, usually there's an initial rise, but after that, there's no large elevation in your somatic cell counts, and then we see a clinical mastitis. All right. So when we talk about subclinical and clinical mastitis, with subclinical mastitis, the cow usually appears clinically healthy. There's no visible change, in the udder. There's no abnormalities in the milk, and but you might culture a pathogen. You might see elevated somatic cell count and bulk tank somatic cell counts, and there might be a drop in the milk production. Okay, so these can be quite chronic, and especially with something like a Staph aureus, and especially if they are resistant to bacteria, to antibiotics. Okay, clinical mastitis. So here we see inflammation in that udder. It's quite clear, red swelling, heat, hardening of the affected quarters. There's visible abnormalities in the milk, including clots, flakes, or discoloration. You'll see a sharply elevated somatic cell count in the beginning, and then after that, like I said, it falls and it returns to a more normal level. And these clinical mastitis cases can lead to systemic signs. And if this occurs, these animals can actually die quite quickly. Right, so they'll have fever, anorexia, they'll stop ruminating, they'll dehydrate, become weak, lie down, and there's obviously a noticeable drop in that milk production as well. They can literally die within 24 hours. Okay. Okay, so when you're looking at let's say the average bulk tank somatic cell count, and you're looking at the clinical mastitis history on the farm. And then once again, this is general. These are general guidelines, and it's not a hard and fast rule. But generally, if say there's less than 25 cases of clinical cases of mastitis in per 100 cows per year, and the bulk tank somatic cell count is less than 200,000, that would be the ideal situation, right? If those cases are low, but the somatic cell count, the clinical cases are low, but the somatic cell count is high, you might be looking at a contagious bacteria problem in that herd. If you have high somatic cell count, sorry, if you have lower somatic cell count than the 200,000 threshold, but you have high clinical mastitis cases, you might be dealing with an environmental bacteria here. And if you have a lot of clinical cases, as well as a high somatic cell count, you might be dealing with a combination infection. And remember, this all also depends on when these samples are taken. If it's taken during the initial peak with a gram-negative bacteria, you know, it might confuse the whole situation a bit. Okay, so the consequences of mastitis. So there are many consequences and long-lasting consequences of mastitis, and that's why we try and prevent it as much as possible. I'm just going to touch on a few here. There's more than what I've put into this presentation. Reproduction is one of them. Okay, so as you can see there, it can increase levels, which then lowers your follicle stimulating hormone, your luteinizing hormone. It can impair estrus, ovulation, oocyte development. Then it can increase your PGF2 alpha. And if you remember from repro, your PGF2 alpha causes corpus luteum to break down. Corpus luteum secretes progesterone, which is important to maintain a pregnancy, right? So that, in effect, then can hamper conception as well as embryonic development. That fever that they develop from mastitis can also lead to embryonic mortality or to abortion, and then that reduction in feed intake, especially if they are systemically ill, then obviously also has long-lasting effects. Okay, so the basic so to take it all together, the reproductive effects that it can have is it can delay the days to service, it can increase the days to conception. Okay, so increased days open, and then elevated services per conception. So overall, an impaired reproductive performance. So when we look at how it affects the milk and the milk quality, we have to look at what are the major components of normal milk first, right? So generally, once again, this will differ from animal to animal. Generally, and obviously breed to breed, we have lactose at about 4.8%. This is the main carbohydrate in the milk. Protein at about 3.3. The major protein here is casein. Very important also for production of certain non-milk products, right? So we'll look at that a bit later. Fat at about 3.5, your minerals such as your calcium and phosphorus, and then water is the major component. So what happens in the case of an intramammary infection is the milk production declines and the total fat production can also decline. They've actually estimated that the milk yield can decline by 2.5% for every 100,000 somatic cell increase above that threshold of 200,000. Okay. Um, Obviously, especially in your clinical mastitis cases, the appearance of the milk changes and then also the composition will change because there's usually quite an equilibrium between the milk and the blood. And now, because of the fact that your casein levels fall, your lactose synthesis decreases, there might be a pool of sodium and chloride into the udder, which can then, and because the body is trying to equalize that osmolality, and that can give like a bitter or a salty taste to the milk. Your casein, like I said, that can impact your non-milk dairy products because of the fact that it decreases. So that impacts especially producers that sell their milk for cheese and yogurt production. Lipase increases, which basically oxidizes that milk fat and gives the milk a rancid or off flavor. And then your somatic cell counts increase and other proteins such as albumin and immunoglobulin. Okay, so what are we going to do when we now have mastitis in lactation? So we're going to look at antibiotics and we're going to have to ascertain how we're going to approach this, right? So is this infection a gram-positive infection or is it a gram-negative infection? If it is a gram-positive infection, which antibiotic am I going to use? Which one is going to be the most appropriate? A gram-negative infection, there is some debate on whether to treat a gram-negative infection or not. I think if you catch it early enough, that might be advisable. If there you need to use your own discretion. I think the reasoning is, these animals are either going to self-cure or they are going to die because they do die really, really quickly. So using your discretion in terms of how you're going to approach that case. And then when we talk about antibiotics, there are the options of intramammary and parenteral. So intramammary, very important to make sure that you don't give a dry cow therapy during lactation. That farmer will not be happy because the dry cow therapy usually have very long withdrawal periods. Okay, parenteral or parenteral, these are usually used, so these would be your intramuscular or subcutaneous antibiotics that you usually then give, especially if it's a very severe infection and the animals are actually systemically affected. Okay, and here you can look at the different options that you have available. Some of the weak base parenteral or parenteral antibiotics can then actually also diffuse into the udder tissue and into the milk. All right, so anti-inflammatories, also very important for the welfare of that animal to treat that pain and that inflammation. And then just important to check for the safety in pregnant animals and whether you can use it in lactating animals as well. Okay, so when you decide on what treatment strategy to use, sometimes there is time to do an antibiogram or a culture, and sometimes not, right? And if there is routine monitoring, it can help you as a vet to actually make those decisions. So even if you do get the antibiogram results back, it's usually a starting point, but you can't rely on it to guarantee treatment success. So when you then select your initial treatment regime for clinical mastitis. But you can also base it on historical culture, on the severity of the infection, and then also the success of previous treatments. Okay, and then the parenteral treatment if systemically affected, like I said. Okay, so what are we looking for if we're looking at intramammary infusion? We're looking for a product that has proven efficacy against the major pathogens that cause mastitis, and especially against the one that is afflicting the animals on farm at the moment. How easy is it to administer? What are the numbers of doses required, and does this fit in with um, the management on the farm? The milk discard time, as well as your pre-slaughter withdrawal periods. Okay, so the dry period. Why is it so important? The dry period, and I think this is Dr. Chris van Dijk's quote, it isn't the end of the previous lactation, but it's rather the start of the next lactation. So very, very important to look after these animals in the dry period, because what happens in the dry period can actually have a lot of effect on the next lactation. Right, so what happens when we're drying off these animals? A lot of our farmers stop milking abruptly. And when that happens, obviously those alveolar cells are still full of milk. It is eventually resorbed. And we then see that if there are damaged cells, they are replaced by cell turnover, they are renewed, and also new secretory tissue is formed. So that means that there'll be more secretory tissue for the next lactation, and therefore that is one reason why the dry period is critical, because it can actually increase the milk secretion in the next lactation. Okay, so we have three phases. We have the first phase, the involution phase, and like I said earlier, the early dry period is quite a high risk period. Now we've said that milk flow stops abruptly, there's no more flushing of the bacteria out of the udder. And then obviously there's a pressure buildup, right? And that can compromise the teat canal. Then we have the involuted stage, and this is where they are generally regarded as resistant. So those protective factors that I mentioned previously are quite high during this period, and hopefully the teat canal is closed by that keratin plug. And then towards the end of the dry period here, the animal becomes more susceptible to infection again, because of the fact that those protective factors are either decreased or they are diluted because she's starting to produce more milk again. Keratin plug might start breaking down, and depending on the antibiotic that you've used, those levels might have started to decrease below the MIC. Okay, so this is what I've explained earlier, is that oftentimes animals will have peak mastitis cases in the early lactation, but that it was actually obtained during the dry period. Okay, so you'll see here that if you look at the red bar, those are infections. So this is the months in lactation. And you'll see that the red bar, especially for your first 3 months in lactation, are actually clinical mastitis cases that were inquired in the dry period. So even though they are actually presenting now in these first 3 months, and I mean, there are red bars up to 8 months in lactation, even though small, but these red bars were intramammary infections that were acquired in the dry period. Okay, so when we look at the dry cow, we have a decision tree there as well. Are we going to give no treatment, which I think no one does? Then are we going to give antibiotic dry cow therapy, which I think everyone does? Most people do, and especially blanket dry cow therapy. Then internal teat sealants, which is a relatively, I almost want to say in inverted commas, new concept, even though we've actually had it in South Africa and overseas. Internal teat sealants are used very often and very successfully. Or are we going to do a combination of dry cow therapy as well as internal teat sealants? So just to give you an overview of what is an antibiotic dry cow therapy and what is internal teat sealant. So obviously, an antibiotic dry cow therapy is an antibiotic, whereas an internal teat sealant does not contain any antibiotic properties at all. There is, with an antibiotic, usually a dry cow therapy, there's usually quite a long withdrawal period. And this will differ from antibiotic to antibiotic. Very important that you look at that and that it's in line with what the client wants their dry period to be, that it's not longer than what their dry period is, right? With internal teat sealants, there's no withdrawal period. It does need to be stripped out. However, it can't be taken out by the milk machine. It needs to be stripped out manually or suckled out by the calf. There will not be any harmful effects to the calf if the calf suckles it out. Okay. So when we look at the antibiotic dry cow therapy, like I said, they usually are formulated to have a long-acting effect and to penetrate deeper into those other tissues so that they can cure existing infections and hopefully then reduce the number of new infections if it's a high-risk animal or a high-risk situation in that dry period. Okay. So let's talk about that keratin plug. We have mentioned it before. So some of the functions of that keratin plug is, like I said previously, to provide a physical barrier to ascending bacterial infections, but then also to inhibit bacterial growth. It has some substances inherent to the substance of the plug that can inhibit bacterial growth. And obviously in a dry period, if there's failure of formation of this keratin plug, it actually leaves that teat canal vulnerable. So these are quite shocking stats, but the one New Zealand study showed that approximately 50% of teats were still open at 10 days after drying off, and 5% were still open 60 days after drying off. That is an entire dry period, right? Another study from North America showed especially your high producer cows have slower teat closure and form less keratin plugs. And there they saw that about 23.4% of teats were still open after 6 weeks, which often also is an entire dry period. They found that udders that actually managed to close were almost twice less likely to develop a new intramammary infection during that dry period. All right, so let's talk about internal teat sealants. So I almost want to say that it's a silicone-like consistency. We call it bismuth subnitrate. There are differences in administration between an antibiotic dry cow therapy and an internal teat sealant. If you are going to use combination therapy, you put in the antibiotic first, and that is the antibiotic is massaged up into the udder, right? An internal teat sealant, you actually have to pinch the teat at the top. And then you just put the internal teat sealant in and you don't massage it up at all. It needs to sink to the bottom of that teat canal and there it will remain. It won't harden or set. You can easily strip it out whenever needed. Let's say it was put in and 2 days later the animal's udder is or that quarter is swollen. You can strip it out. It's not something that's now permanent, or it can stay there for up to 100 days if you don't strip it out. However, you can strip it out if need be, if you need to get that to treat that udder for whatever reason. Okay. Right, so like I said, it does not have an antibiotic function. It can't kill bacteria or cure an infection that is already in the udder. It's purely a physical barrier to environmental bacteria from entering that teat canal, especially in animals that don't form a keratin plug. Right, so if an animal has a suspected clinical or subclinical mastitis, you should not be treating with an internal teat sealant only. There you would go for combination treatment. And especially with any intramammary, but especially with an internal teat sealant, it's very, very important that you work as hygienically as possible because you don't want to introduce pathogens and then actually close them in there. Okay. Teat sealants are very effective to protect that quarter from new environmental bacteria entering into that udder. And also, like I said previously, with some of your antibiotic dry cow therapies, the levels might start dropping to below the MIC, and sometimes then that leaves that udder vulnerable in the last few weeks or days of the dry period. And that is where the internal teat sealant will also come into play and keep that udder protected. Okay, so let's look at some studies and what they found. This was a meta-analysis, which is one of your best type of studies. What they found for herds that used an internal teat sealant. Okay, so what they found was that for intramammary infections, the use of an internal teat sealant either by itself or along with an antibiotic dry cow therapy, so in other words, a combination treatment, reduced the risk of fresh lactating cows acquiring new infections by 25% compared to just using an antibiotic. Okay. If you compared using an internal teat sealant to animals that did not receive anything, no antibiotics or anything, nothing, it reduced the risk of intramammary infections by 73%. Okay, so for clinical mastitis cases, they found that the use of an internal teat sealant by itself or along with antibiotic and combination therapy reduced the risk of clinical mastitis in fresh lactating cows by 29% compared to just using antibiotics. And then the use of that internal teat sealant reduced the risk of clinical mastitis by 48% if you compare it to untreated animals. Right, and then very quickly, I have to mention antimicrobial resistance. We have to mention, the increasing concern of antibiotics in food-producing animals and the responsibility that we have as veterinarians to develop a strategic and focused approach when it comes to antimicrobials. Okay, so we need to, I think the main definition of responsible use is using as little as possible, as much as needed, without compromising the animal's health or welfare or productivity. Okay. So what they do in New Zealand, for example, is they treat clinical cases, that's acceptable, but their use of antibiotics at dry off actually needs to be justified. Right, so there are some countries where it's actually law to, I think it was Denmark, where selective dry cow therapy is actually now written into legislation, I think since 1995 already. So I think when you look at antibiotic dry cow therapy, look at what is the risk of this animal developing an intramammary infection. So there you can look at the history, the records of clinical mastitis. You can look physically, do a clinical examination of that animal, look if whether there are teat lesions, palpate that udder, and look for any signs of fibrosis, etc. Each farm is different and will require a different approach, and you can then also just look at the somatic cell count, the pathogen profile of the herd, if that is available, and constantly reevaluate the situation on the farm to make sure that whatever you are advising is still appropriate and justified. Okay, so some of the things that you can look at: bulk tank somatic cell count should be readily available. Individual cow somatic cell count, not so much. That would be ideal, but unfortunately that's not readily available. California mastitis milk test and clinical mastitis records, and then if they have culture results available. Oh, sorry. Okay, and then also think about how long is the dry period on that farm and how does that relate to the milk withdrawal period of this product that I want to advise. Do I have an idea of what are the main pathogens that cause mastitis in this herd? Look at risk factors of animals developing new infections during the dry period and at calving. And then what are the consequences of missing an infection or treating an uninfected cow. Okay, so your sensitivity versus your specificity, right? So what do you regard as more important? You know, identifying the true positives, or perhaps then treating some of the uninfected animals with an antibiotic. What is the spectrum? Is it a broad spectrum? Is it a narrow spectrum? And then once again, especially with narrow spectrums, I think very important once again to just hammer on hygiene with intramammary administration, okay, because you can introduce an environmental bacteria into that udder even when you put in antibiotics, especially a narrow spectrum antibiotic, and you don't do a good job of the hygiene while you're doing that. Okay. Selective dry cow therapy, I'm just going to mention what it is, maybe for those of you who are not sure. So blanket dry cow therapy is every animal receives antibiotics, right? Whereas selective dry cow therapy, this is much more tailor-made in terms of which animal receives an antibiotic in addition to, say, an internal teat sealant, or just an internal teat sealant, or perhaps no treatment at all, but I don't think there is anyone who goes for no treatment at all. And how they do this is the UK, they first look at the herd, and there is a lot of information available. If you're interested, you're more than welcome to contact me. They first look at the herd, right? So they look at, you know, how's the management and the record keeping, etc., the hygiene on this farm. What records do they have available? Then they look at the group of animals that they are considering for selective dry cow therapy, and they look at whether these animals are high risk or not, and go from there, and then go down to the individual cow. Okay, so it is quite intensive. There are, I think, a handful of farms in South Africa that is applying selective dry cow therapy at the moment. And this is something that's definitely worth thinking about and moving towards, even though we aren't necessarily there yet at the moment. And this is also just so I've said there at the top, this might be the dream for the future, right? So this is just an illustration of what they do in the UK, where they look at the bulk tank somatic cell counts, and then from there look at the clinical mastitis records. They have individual cow somatic cell counts available, and then from there they make their decisions in terms of, are these animals only going to receive an internal teat sealant? Are they going to receive combination therapy with a broad spectrum antibiotic, or are they going to receive combination therapy along with a narrow spectrum antibiotic? Right, my references are available if you need them. I'm sorry, there's not a lot of time for questions, but please write down my email address. And then if you have any questions, you are more than welcome to contact me. Okay, thank you.
Thank you, Dr. Chantelle. Well, we've got some questions here, and we can go through it. One person asked, if your somatic cell count sits on 90,000, is there still chance for improvement, and what can we do to bring it down more?
90,000 is quite low already. I suppose there is still chance for improvement if you'd like to. And I think that's hard, because I mean you would have to look at what is that made up of? Are there maybe animals it's that somatic cell count there's so many things that affect somatic cell count. I mean, milk machine can affect somatic cell count. Any damage to the udder caused, say, by the milk machine can increase your somatic cell count. Any types of lingering infections, and there might be, remember, so I assume that you're talking about bulk tank somatic cell count of 90,000. There might be one or two cows that are drawing up that average. And then also you need to look at the stage of lactation. I mean, if they are towards the end of their lactation, a higher somatic cell count is not necessarily abnormal, but I think 90,000 is really not bad at all. So yeah.
Okay, thank you. Then another student had some sound problems, and he just wanted you to repeat what DC stands for. When you spoke about treatment you should not give during lactation, and that was on slide 52.
Oh, that's dry cow.
Dry cow.
So yeah, don't. So it has happened before where, especially if farmers store their dry cow, which usually on the tube it says DC, and their lactating cow, which it usually says LC on the tube. And if those tubes look very similar, they might just be in a hurry and grab the DC instead of the LC. And then they treat a lactating animal with a DC or a dry cow therapy. And I mean, just the milk discard with a dry cow therapy can be anything from, I mean, 30 days to, you know, yeah, much longer. So that, you know, that means a month or more worth of milk down the drain that they have to literally discard.
Okay, thank you. And then with regards to the keratin plaque, which forms when a cow is dry, what happens to it prior to lactation so that the teat canal can be open?
It just starts breaking down with the normal physiology. Yeah, if you want to know, like at cellular level, I'm not entirely sure. I'm sure there are enzymes that break it down, etc. But it's basically broken down by the body and resorbed. Yeah, but at cellular level, I'll need to I'll need to do more research.
Okay, and then the last one for infectious mastitis, which has subclinical symptoms. It usually has a diagnostic high somatic cell count with multiple peaks, which is primarily composed of leukocytes, but can this be confused with significant T damage, which will have a high somatic cell count, but composed of epithelial cells?
Epithelial cells.
Epithelial, sorry.
Yeah. I suppose it can. I think you can do a milk culture to see what's going on. You're not going to necessarily get a positive culture on all those cultures. But I suppose, yeah, I think when you approach something like a high somatic cell count, like I said earlier, there are multiple causes of a high somatic cell count. So, I mean, if you have a high somatic cell count, it can be because of other damage, like I said, caused by the milking machine, or it can be a subclinical infection. And I think just looking at the whole herd and looking at the history, looking at the milking machine, and that is why I think as veterinarians, we need to have a more integrated approach when it comes to our dairy farms in terms of, and there are many vets that are doing a very good job in terms of where they become part of the herd management. They have a herd management approach, right? So they become such an integral part of that farm, and they're not just there for a PD, but they're actually on the milking table where they actually look at how these animals are being milked, what the hygiene is like, etc. So yeah, and then looking at the clinical mastitis records as well. I mean, it might be that there are some spikes of clinical mastitis cases as well. So just looking at the whole picture, I think, is the best way to go.
Okay, then the last question so far. Can the problems regarding teats not closing properly in herds be rectified genetically?
That is a good question. I'm not sure. That is a good question.
Okay, David van 'n Rijst asked that question.
Okay. David, I don't know if you want to pop me an email and then I'll go and see if I can find any info on that.
Okay, any other question before we close the session? Okay, thank you, Dr. Chantelle, for your informative session. You've got a thank you here as well on the chat group. And so thank you from our side. It was wonderful listening to you.